I'm Steve Thompson, certified Lean Six Sigma Master Black Belt, and I currently serve as Vice President of Supply Chain Innovation for Cardinal Health. This recorded webinar supports a recent video posted by Cardinal Health entitled Demand Amplification. A lot of changes in healthcare recently, putting a lot of pressure on both providers as well as the entire supply chain. When you think about the Affordable Care Act and the implications of changes in reimbursement, as well as the FDA's unique device identification law, it is changing the way that we do business. But at first I want to talk about what's going on in the background. We hear this a lot, that 10,000 people a day are turning 65. There's actually much more going on than that. In 1965, when the Johnson administration enacted Medicare, there were somewhere between 4.5 and 7.2 people working for every person retired. Median life expectancy was 71. Today, there are 3.2 people working for every person retired. Median life expectancy is 79, and there are currently over 10 million Americans over the age of 80. By 2022, there'll be 2.3 people working for every person retired. Median life expectancy is projected to be around 82 years of age, and there'll be over 20 million Americans over the age of 65. By 2026, over 20% of the American population will be over the age of 65. In their working life, the average couple in this country contributes $137,000 to Medicare through payroll deduction. And yet each will withdraw $337,000, as 90% of your life's expenditure for health care is in the first and last year of life. And if you think about what typically happens in a hospital when there's financial pressures, CFO will look at their balance sheet, and the largest bucket is labor at 55%. And we have squeezed about as much labor as we can out of healthcare. The next largest bucket is materials management, with 35% of the spend. So we're becoming more and more important to a CFO. So let's talk about the history of demand amplification. The video that you watched does a very nice job of explaining how the phenomenon works. It's first detected in the 50s by J. Forrester at MIT, and it was called the Forrester Effect. And what the Forrester Effect identified was that in industry, primarily, supply chains were affected significantly by changes in variation. So the further you got away from the source of the variation, the larger the variation became. It was coined the Bullwhip effect. So if you think about snapping a whip, and you can watch how the further you get away from the point of the snap, the bigger the whip becomes. In the 80s, this concept, in order to teach it, was developed at MIT Sloan into what they called the beer game. And the beer game was a fun way to show folks how this phenomenon worked. We have since adopted what we call the supply chain game based on the same principles. We just don't drink beer while we're doing it. Industry understands demand amplification. This is actually a concept that was brought to Cardinal Health by the Master Black Belt that joined 10 years ago when Cardinal first started becoming a lean enterprise. A classic example of how this works is the H1N1 virus reaction. If you recall, demand on N95 masks was so great that global production could not keep up with demand, and folks were hoarding and hiding, and the entire system was running out, to the point where there were counterfeit N95 masks entering the supply chain. Now, thankfully, Cardinal Health has very strict guidelines in place, and there were no counterfeit N95 masks that came through our channel. But at the end of that crisis, suddenly there was a glut of N95 masks, and everyone stopped ordering. This created a secondary problem because when there are no orders, there's nothing to manufacture. Manufacturers basically stopped making N95 masks. Then when orders restarted, there was a secondary panic because people couldn't get them. Same thing is happening currently with Ebola. If you think about the fact that we have customers that have never ordered isolation gowns, and suddenly they're ordering by the skid load. And production for isolation gowns has been ramped up to max. You got to wonder what's going to happen. through the Ebola crisis that the same problem is going to emerge. Challenge is either you have the right supplies or you don't, and it's all influenced by the initial signal. Now, I am not sitting here today saying that the customer is to blame for the condition. The customer does not create the variation, nor does the customer cause the conditions that make the variation. However, the customer does contribute to the difficulties that we have in the supply chain by not being able to react appropriately to these variation signals. Recently had a customer say, hey, isn't this what we pay you to do, to manage all this variation for you? And the answer is, yeah, that's exactly what you pay me for. That's what you pay everyone in the supply chain for. My question back is, are we happy with that? Are we happy overpaying for everything? Or do we want to be able to take as much cost as we possibly can out of our heavily compressed supply chain? So the bullwhip, or the demand amplification signal, really starts at the initial trigger of demand. So if you think about the point of truth being where a take happens of an each, and how that take is recorded then goes on to create different variation effects that we see as what we call demand amplification. And the result is typically too much or too little inventory, or inventory in the wrong place, and an inaccurate forecasting mechanism. So when you think about the impact it has on healthcare, and you compare this to industry, the difference is, frankly, we don't have what I call a defined supply chain. Industry has vertically integrated supply chains, and typically will work to a central portal, meaning when the end user has a source of variation or a change in demand, the entire supply chain sees that change at the same time and is able to react appropriately. Unlike our supply chain, which really moves from MRP to MRP to MRP, there can be literally weeks between when a demand signal is changed to when a manufacturer or raw material producer sees that change. Another difference is that industry typically works in blanket POs, meaning that there is a commitment for a larger quantity over a given period of time. We tend to do a series of discrete purchases. So each purchase happens independent of every other experience. You think about something as simple as lap sponges. If we're using multiple vendors for lap sponges, then we're sending conflicting signals into the supply chain. Also, we are one of the very last industries, if not the last industry, to still use the PAR system, the periodic automated replenishment system. And I believe that the one to get out before us was grocery stores. And it's sad to say, but grocery stores have actually adapted to a lean model, and in a lot of ways have a superior supply chain methodology to what we have in healthcare. Think about something as simple as UPC codes. Every single item that you can purchase in a grocery store has a defined UPC code. You'd never see a grocery store having to over-label cans of peas so that they can be read at the cash register on the way out. We as an industry have yet to adapt or adopt to a single barcode methodology. Cardinal Health is a supporter of the GS1 model. We believe that everyone should be on the same platform. There is a tremendous amount of cost locked into our systems because of the fact that we don't have a consistent barcode. But the other thing that goes on with the grocery store is they're able to use data analytics at the point of sale. So as items are scanned, the grocery store is able to use that as not only a replenishment methodology, but also a methodology for detecting variation, and to be able to either detect or predict changes in variation based on those patterns. Hospitals tend to be very reactive in supply chain management versus industry, which is very proactive. And so the question is always, hey, what's the right time to order and how much? And part of the reason we have such a problem relative to how industry works is we lack a procedural bill of materials. So if you think about a manufacturer, upon completion of each of a widget, a bill of materials will show how much went into making that each. How much metal, how much plastic, how much paint, how much electricity, how much labor. You actually know exactly what you use, and it gives you not only a stronger mechanism for costing, but it also gives you a very powerful mechanism for replenishment. We typically buy to replenish a void. It's to make a hole, fill a hole, and in doing so, we lack predictive capabilities because what we don't have is a mechanism to visualize demand. On top of that, we do a lot of manual counting, and anyone who's ever done a physical inventory knows that counting creates as many problems as it solves, whether it's through fat finger issues or unit of measure errors. And what this really comes down to is we haven't standardized the delivery of care. Something that was really well highlighted in the video that accompanies this webinar is this concept of multiple variables and the effects of multiple variables happening on each other. We've identified really 4 primary sources of variation: demographics, census, seasonality, and clinical practice. And clinical practice includes the different disease states that we're treating. And oftentimes disease states are affected by both clinical practice as well as seasonality and census and demographics. So let me highlight this with an example. If you think about how the population moves different times of the year, whether in the wintertime moving to southern Florida or Scottsdale, Arizona, for example, or in the summertime with folks flocking to the Jersey Shore, we see these large changes in demographics, census, disease states, clinical practice, and seasonality. If we're talking about a Florida in Boca Raton, rather a hospital in Boca Raton, Florida, for example, and we look at the hospital in July, it's got a census of maybe 65, 70%, and a median patient age of 55. Leap forward to November, that same hospital has now got greater than 100% census, has a median patient age of 75, and those patients are presenting with a very different set of disease states. And also, we've had to ramp up our clinical staff to support this larger census, which means that those are folks who typically live in Wisconsin or Michigan or upstate New York in the summertime and move to Florida in the wintertime, and those 30-year, tenured clinicians bring a very difficult to change clinical practice with them. And then all of a sudden the flu hits, and we're always surprised when the flu hits. And so not only do these individual variables affect demand variation, they affect each other. Let me give you an example. If we were a tire company, and I, as CEO, asked everyone to go out and to develop based on their specialties. So I went to one group and saying, hey, we're going to make a brand new high-performance tire. I need you to work on hot conditions, and to another group, cold conditions, and to another group, wet conditions, and to the final group, dry conditions. And each one of those groups wildly surpassed the expectations of their testing for each of those conditions. Put those brand new tires on my high-performance sedan, and on the way home this evening I crashed because it was both wet and cold at the same time. Wet and cold, individual variables, together create another variable. And so this is something that we are unable to detect or manage given the current constraints that we use in healthcare inventory management. So the question is, so how do we replenish? There's really 2 kinds of ways to do it traditionally. The first is the traditional forecast-based purchasing system. Now, I got to tell you something. I kind of live my professional life on three principles. The first is that batching is bad. The second, that variation is evil. And the third is that forecasting is what I call the F word. And if you think about it, forecasting is never accurate unless you're lucky enough to have a clairvoyant on staff. So therefore, my question is, why would you even do it? Forecasting is essentially the retail model of purchasing. Retail is able to survive doing this because they charge so much at a retail price that they're able to compensate for the costs in the system. The reason why jeans are so expensive is that the cost of shoplifting is baked into the price of the jeans. And frankly, it's this condition which has caused the availability for big box post-retail sellers like TJ Maxx or Marshalls, for example. It's essentially a stocking strategy versus an inventory management strategy. And what's great about it is it doesn't take a lot of effort. What's bad about it is it's not very accurate. You get very little visibility, and it creates this sort of storage solution mentality. The other way to do it is traditionally using a demand-based system. And this is really based on what we learned from aerospace and automotive and the other large vertically integrated supply chain businesses. And it's based on utilization, this idea of make a hole, fill a hole. I use something, and so that's my trigger to replenish. And it works great, assuming that there's very little variation in demand. Problem with it is that as there is variation in demand, it requires you to have either a very reactive supply chain, or frankly, you're going to end up with the inability to react quickly to unexpected demand variation. So there's a balance here, right? And to find the right balance, let's first talk about what the ideal situation would be. What would utopia look like for those of us in supply chain management? And first is we'd have the right inventory available at the right time, and stockouts and overstocking wouldn't happen, and we wouldn't be required to count, and clinicians would be happy and satisfied and confident that every time they needed something, it would be there. And part optimization would be done with technology, wouldn't require any kind of human intervention. Anything that was recalled, expired, or obsolete would be immediately identified, so we wouldn't have any patient risk. And then we'd have some kind of great data platform that would inform decision making. As a person with a Lean Six Sigma background, I idolize D. Edwards Deming. And Deming, if you don't know, was the person who brought us the concept of statistical process control, which evolved into what we know today as Six Sigma. Deming would have said, hey, without data and facts, all you have is just another opinion. So the question is, how do we get to this ideal utopian situation? So there are some best practices that we've identified. We Cardinal Health work with literally thousands of different acute care facilities. And it gives us the ability to see some best practices and make some recommendations. We are members of a number of industry bodies, and you think about something like the Unique Device Identification Law and the requirements that are put on manufacturers. And if you're not familiar with the law, essentially this is a manufacturer-focused law that tells those folks making Class 3, Class 2, Class 1 devices, implantables, that they have to have serial-level control and identification of their eaches, and to be able to know at each level the lot tracking and expiration information. You got to believe that in 5 years, when this Class 3, Class 2, Class 1 devices have all been rolled out, that the next expectation is for us as providers and distributors to be able to adapt and adopt, to be able to use these technologies for things like electronic medical records. We are going to have requirements, legal requirements, that we haven't seen in the past. And I got to tell you, it surprises me. I used to ask when I first heard about this how it could be that we don't already have this in place, and folks would say, well, it's not something that we have the capability to do. And which surprised me, because coming from an automotive background 25 years ago, I knew exactly what airbag was in what car and who owned it. So this is not new technology. This is just a new application. Get a lot of questions about charge capture and data capture. It's interesting that that what we're seeing as the move away from reimbursement in its traditional form to reimbursement by DRG, that the bundling is really changing the mechanism behind the mechanisms we use to do traditional charge capture. We have a number of customers that are moving away from charge capture in non-procedural areas. because what they come to realize is they're spending more money doing accounting than what they're actually seeing in reimbursement. But more importantly, even if we are doing charge capture for expensive items and data capture for electronic medical records, oftentimes we're doing it today manually. We're requiring clinicians to do manual work, and there are a lot of errors made, a lot of things dropped and lost, and there is an unseen loss of income and data records because of the current system. Also, frankly, we should be eliminating manual counting as much as possible. The reason why we have to count today is because we have non-capable processes. If we had processes that allowed us to be confident in what we have on hand, we wouldn't have to count. Counting causes as many errors as it fixes. And finally, this idea of open versus closed access systems. Once upon a time, we had this idea that since the nurses are already going into the cleaning supply room, we'll just have them do the inventory management for us. And we gave them closed cabinetry systems that they would have to log into, find a patient, find a product, do a cross-reference, unlock a cabinet, take a component, finally close the session. It took anywhere from 45 to 75 seconds per transaction. And if the clinician does it 120 times a shift, that is 2 hours of their day essentially doing supply chain work. We know from TCAB, the Transitioning Care at the Patient Bedside initiative from national nursing groups, that there is a correlation between time spent at the bedside and the quality of the convalescence and the likelihood to readmit within 33 days of a procedure. And the more time the nurses spend away from patients doing supply chain work, the lower the expected convalescence quality. From a commodity standpoint, there's really two systems that make sense. The first is what we've always done, which is the PAR system, periodic automated replenishment. And then there's tubing Kanban, something that we learned from Toyota. And it's interesting, I have a lot of folks say, hey, Kanban seems like such a low sophistication in terms of technology, it doesn't make sense. I feel like I'm going backwards if I'm going that way. And yet, the greatest supply chain company in the world, Toyota, still uses tubing Kanban as their primary source for replenishment. They've been doing it for over 50 years. The problem with the PAR system is, and people say, aren't they kind of the same thing? And the answer is they are not the same thing. A PAR system establishes a min and a max based on a point in time and expects that when you get down to a min or a reorder point, you're going to order back up to your max. Seems like a really neat idea, except now you're requiring typically people to go and look at things every day. A 350-bed hospital is going to have anywhere from 20 to 30,000 individual stocking locations. And so we're expecting people to look at these things and be able to determine how much is left, which means they're counting, and order back up to a point. And in that condition where we had, say, a max of 24 and a minimum of 12, when they go to look, it's not always at 12. So you're sending orders into the system, which is maybe 11, then 9, and 13, and 5, and 17, and we're creating yet another source of variation. Essentially it's randomizing, if you will, the stocking order versus a Kanban where an empty bin is their signal to replenish, and the empty bin is always the right count at 0. So you never need to count because it's essentially a perfect counting mechanism. Further, when someone goes into a stocking location to replenish, we expect them to take the old material and pull it forward and put the new material in behind. So let's assume that they're actually doing that. Although we all know, based on the fact that we can go into any facility and find expired product available to a patient, that it doesn't happen every time. We call this first in, first out, right? FIFO. The opposite to FIFO is something I call FISH, or first in, still here. A Kanban supports perfect FIFO and lot control. Also, a Kanban, if done correctly, should be utilizing a logical unit of measure so that we're able to spend less time picking than we do today. Cardinal Health has spent a lot of energy over the last couple of years developing what we call the Cardinal Health Inventory Management Solutions. It's a suite on a single platform that manages all of the components in your system. And it's an inventory management system that you would need to be able to track, trace, or control at the high expensive end, or all the way down to the inexpensive consumable products that you would be able to manage in a Kanban. So and I really like this slide, this graphic, because it really shows that one size does not fit all, and you don't need multiple solutions to fit your multiple expenses and products. That really it can be done on a single platform. Let me give a couple case studies. The first is at Emory St. Joseph's Hospital in Atlanta. This is predominantly a procedural implementation that, as you can see from the graphic, shows that significant time has been saved in labor just ordering products every day. We significantly improved inventory turns, 60%, automated expiration or recall alerts. We're able to track 100% of short-dated products to avoid any expiration. And on top of that, we've reduced aging by 84%, recovered about $300,000 in chargeable products that would normally be lost because of the manual processes. And on top of that, we eliminated accounting. Also, 100% elimination of supply costs due to stockouts for overnights. This is a clinical pleaser. Folks who work in these environments love this solution because it makes their job so much easier, so much more predictable. As we were developing our inventory management solutions, we realized early on that given the unique device identification law that we would want to be able to employ an RFID solution, and started looking at best practices with the intent to develop our own. Going through this, we found a company called Wavemark. Wavemark was identified as the best practice, and we were able to acquire it. And we were able to connect Wavemark's already stellar solutions and capabilities to what we were developing for commodity products. And this is what went together created the inventory management solutions. We're running about 2 years now at Bellevue Medical Center in Omaha, Nebraska. And this is more of a med-surg implementation. And we've been able to reduce the amount of time that clinicians spend getting supplies by 40%. We reduced the amount of time it takes to put supplies away by 40%. We eliminated cycle counting completely, and yet we've got a 35% sustained reduction on on-hand inventory. So thank you very much for listening today. If you have any questions or you would like more information, you can go online to cardinalhealth.com/CIMS for Cardinal Health Inventory Management Solutions, or you can contact us at 614-553-5322 or email us at gmb-cims@cardinalhealth.com. Thank you.